In this episode of the Nurse Practitioner Podcast, Christine Kessler discusses obesity. Thanks so much for taking the time to chat with us today, Christine.
Welcome. Happy to.
All right. So first, what initially got you interested in obesity medicine?
Well, I came to obesity medicine actually as a nerd. And what I mean by that is that I have been a pathophysiology geek for most of my nearly 50-year career. I always had a need to understand the biology and the physiology of what I'm seeing in my patients, how they clinically present. And I continue to do that now. Now, how this all began was when I entered full-time endocrinology practice about 23 years ago. And I quickly noticed that about 80% of my patients struggle with overweight or obesity. And by the way, for this talk, overweight is pre-obesity. So we need to think about that. But I started seeing that, and I call it adiposity. And I saw it in 80% of my patients, and I saw very quickly a link between this adiposity with type 2 diabetes, actually with hypothyroidism, and I saw it with cardiometabolic disease. And I started realizing there was a connection with this fat mass. So I started studying fat mass, and I studied adipocytes. And I realized that fat tissue, adipocytes, are very chatty, and they actually release all sorts of hormones and peptides, and a whole lot of them are related to inflammation and inflammatory cytokines. And that was astonishing, because during my 20 years prior as an acute care nurse practitioner, CNS, in critical care, sepsis and cytokines and cardiovascular medicine was my specialty. So I saw this connection, and I came to the conclusion fat mass was indeed an altered fat mass, or obesity was actually a disease state. Now, knowing that, and because I have to yammer about it, I started talking about obesity as a disease state in 2004. And regionally, in the D.C. area and in the states around, it was in 2007 I went national, and talking to my colleagues throughout the country about the disease state of obesity. And been doing it ever since then. But what I started out doing is trying to raise the alarm, like a Paula Revere. I saw this as a huge metabolic disease that was not changing. It's not going to go away. It was going to continue. And I started calling it things like fatal fat, or I once said fatal fat and the sweetheart syndrome. I called it cardiobesity, diabesity, these terms that weren't used in those days, to try to show the disease state of obesity affecting these other disease states. Sadly, they were interested, but nobody carried it through. What does this mean? Who cares? Yet I kept talking about it. The reason was, although this was a disease state and I knew it, we didn't have a lot out there at that time. Surgery was very difficult. We had no good medications. That, of course, has changed, but something pivotal happened, colleagues, in 2012. In 2012, the AMA came out and called obesity a disease state. And at that point, money flew in to research to help these patients who struggle with this devastating disease. And that gave me enough gravitas to start my very first weight loss clinic a half day a week in my endocrinology practice. So that's how I got to it.
Thanks for sharing your background with us, Christine. Next, why are we seeing the continuing upward trends of obesity in America?
Well, that's a simple question. The answer is complex, but I'm going to try to keep it, a little more simple. We do know, and you can just look around, that America now is over 75% of us struggle with the disease of overweight and pre-obesity. Now we're 46% over the age of 20 struggle with the disease of obesity. And we know over 16% of children do, 1 in 5 adolescents. So we see this all around us, and it's not going to change. The interesting thing about the obesity epidemic is it actually made its appearance in the United States in the late 70s. Now, I'm a child of the 50s and 60s, and even started medicine in the 70s. At that time, we didn't really see a lot of overweight or obesity. We just didn't. Look at the old movies. It wasn't there. And suddenly it came on, looking at this, and when we saw it didn't really start just then. You have to understand that this thing started, the harbinger started probably in the beginning of the last century. And what's gone wrong, to your question, is a combination genetics, environment, and biology or epigenetics. The big player in developing this disease of obesity is genetics. But that only explains about 60 to 70% of why somebody has a proclivity to gain weight or abnormal fat mass. A lot of it is explained through the environment. The changes come through environment, which leads to epigenetics, resulting in biohormonal disruptions that lead to abnormalities in, and this is important, energy intake, energy storage, and energy metabolism. So something went wrong. But genetics, DNA, is not destiny. So we know that this is related to a lot of the environment that's going on that began probably the beginning of the last century. And I call it better living through chemistry and easier living. So, for example, the biggest environmental influencer has probably been endocrine disrupting chemicals. Colleagues, we've known this for 20 years. And you don't hear a lot about it. You are going to be hearing more about it recently, but we've known that these endocrine disrupting chemicals have led to fertility issues, thyroid issues, type 2 diabetes, and weight gain, adiposity, obesity. When you think of environmental disrupting chemicals, think about the alterations in our food growing practice that have happened over the last century. We're thinking about pesticides. We're looking about how we store the food, how we wrap them. We're looking at, it's not the meat, it's not the animals we eat, it's what the meat eats. What are we injecting them? What are we feeding them? We've enhanced our food, dense carbs. We have flavor enhancers, color enhancers, storage enhancers, shelf life extenders. We've been extended. And get this, it's not just the food we eat, colleagues. It's also what we put the food on. It's what we breathe in the air. What's the outgassing? It's the plastics and the PBAs, what's coating your receipts. Why do our shirts and clothes don't wrinkle? What is that we're absorbing in our skin? Why is cheese yellow? Cheddar. And here's another one, toothpaste. Preternaturally white. It's what they've added to it. Considered safe. And so there's a lot of that going on in the food sources. So think about disruptions in the microbiome, because that's what it's all about. Disordered microbiome from what we've been exposed to. Now, when you're looking at the other things besides the endocrine disrupting chemicals, the number one is sleep. That's another epidemic of poor nutritive sleep. People are not sleeping for a lot of reasons we won't get into. So not sufficient sleep. And the other one is stress. So impaired sleep and stress. And why I say that, colleagues, is because these two influencers actually increase cortisol levels in your body. And what does cortisol levels do? Hypercortisolism. It makes you gain weight. Where? Around the middle. You get adiposity. So it does promote weight gain. So we've seen all this for a long, long time. And we've seen these startling trends in weight gain and obesity. But colleagues, we've been ignoring it for decades. And we're not anymore, fortunately, but shame on us for not addressing it sooner.
That's a bit jarring to hear. Hopefully we can reverse the obesity trajectory in America.
Can I just share with this? There is no end in sight. That ship has sailed. There's no cure for obesity, and there's no reversing. But we can control it, so that's our goal.
What do you feel are the most important points clinicians should understand in managing obesity or adiposity?
Well, I like what Dr. Lee Kaplan said. He's an obesity GI specialist out of Harvard, and he said this, good place to start. Overeating does not cause obesity. Obesity causes overeating. What do you mean by that? It's the pathology, it's the broken biochemistry, the signaling in the body that leads to obesity and disordered eating, and not the other way around. So that's an important way to do it, because developing this disease, colleagues, is not really the patient's fault. It's not their fault they have a proclivity to develop adiposity. No more than it's their fault they develop type 2 diabetes. And we know this. We know this. People can eat thousands of calories, not move much around, have a slothful life, and or eat Krispy Kreme donuts all day and never develop obesity or diabetes. And we know this. And so there's another reason for it. So they have a proclivity for that. So to think that it's their fault, and it can really hinder our treatment. And understanding this is a disease, it is not a character flaw, and thinking this can lead to bias, not just by providers, but also by the patients themselves and those around them. But it does lead to medical inertia, and that's something we want to prevent. Now, when we talk about this being a disease, this is another take-home point. Providers should know. Obesity or adiposity, because by the way, it's not numbers on a scale. I'll talk more about that in a minute. Adiposity is a chronic, progressive, a multifactorial, inflammatory, relapsing disease. It's chronic. That means once you have it, you don't get rid of it. Just like you have dyslipidemia. You've got it for life. You have to be treated to some way, pay attention to it for life. So it's chronic. It's progressive. It has a lot of side effects like prediabetes. People come into the diagnosis of diabetes. I'm using my finger, parentheses here. It comes into that. They've already had some complications related to the disease. So it is progressive. The longer we delay in treating, the more complications they're going to get. And is multifactorial. We just talked about that. It's inflammatory. I mentioned that with the first question. It causes a constant systemic low-grade inflammation, making every other inflammatory condition worse when you have adiposity. And it's also relapsing, and that's the biggest frustration, that there is a lot of weight regain. More on that in just a second. Because this is such an inflammatory condition, it is important to understand this other thing. We have to focus not on weight loss or numbers on a scale. We have to focus on improved health, improved metabolic markers. That's the goal of treatment. And the patients must understand this. It's not going into skinny jeans, looking nice, slim, and all that. It's not that. It's looking at health markers, metabolic health. And that should be the goal, because the target and how we go about that, they don't have to lose the 70 pounds they think they need to lose to get to more metabolic health. The other thing I think to make important that people understand is that's the idea. I've been talking about fat mass. It's important, I think, for providers to understand that fat mass is an organ, much like the heart, the gut, the brain, skin, gonads. This is an organ, colleagues. And like an organ, it has a role in the body. In fact, this one does. Fat mass has immune and endocrine functions. You may not have known that, but we know it's essential for life. Fat mass is essential for energy storage and regulation. Without it, colleagues, we couldn't live 24 hours. We would need to eat constantly eat to maintain caloric intake or energy intake so that we can get our heart to pump, lungs to move, brain to think, and the like. Okay, we could not survive it. So energy is stored in fat mass. And it's such an important organ, by the way. No matter what happens, if it starts enlarging, the body will defend that fat mass. Again, if you've not even had a little, even the skinniest people has to have a little bit of fat mass to survive. But the body will defend that fat mass. So one thing that we know then, it is an inflammatory. There's two different kinds of fat mass. Things will happen. The fat mass can expand in size by hyperplasia into the subcutaneous area. Consider that our upholstery. It's what some of you are sitting on right now. That's subcutaneous fat. And that's not a bad fat. They can get big and become cumbersome and affect joints with the weight. There's that fat mass. That's the outside fat mass. But the problem gets into is that you no longer can store energy in subcutaneous fat. It goes into the viscera, becomes what we call ectopic fat. And that's important for you to understand. It's the ectopic fat, the one that's in your liver, on your omentum, I've seen pancreases totally obliterated with fat, making people receive insulin for the rest of their lives. It could be around the heart. So it could be all over the place. And this is a different kind of fat mass. We call it sick fat because it's very hypertrophic and it releases all the inflammatory cytokines that I mentioned before that causes a lot of the insulin resistance that you see in type 2 diabetes and cardiovascular disease and many, many other things that it can lead to. So that's important. So we know this is an important organ for energy, and the big regulator of energy is the brain. So here's another thing to understand is that obesity and adiposity is being considered a brain disease because the brain's the one that regulates the satiety area in the brain. It's the one that controls how much you should consume, when you consume, because we have to consume energy and then it's stored and then we release it. And the brain determines when you release it, how much you need to handle the stress the body is feeling. If you're exercising, the brain will determine that. And it determines the energy expenditure of your body, particularly the resting metabolic rate, which is about 70 to 80% of the energy you expend. So just sitting there now, you're expending a lot of energy, and that brain is the one who's doing it. And something can go wrong in the brain in that communication. So again, managing obesity is not about numbers on a scale. It's about the adiposity. You don't have to be what we call obese. You can be skinny or be normal weight and have severe adiposity, visceral adiposity. So, and that's the hardest to treat. So you can still have cardiovascular disease related to adiposity, but not be obese. You might be a little overweight, or the like. And that's the other thing to be mindful of.
We hope our listeners find these insights on fat mass helpful.
Yeah, well, we wear it around and we're pinching it and we're looking at it in the mirror every day.
Next, lifestyle is considered foundational when treating obesity. What are the most impactful changes in lifestyle, such as diet, physical activity, and other behaviors?
Well, I think before we even get to those few points you mentioned I think you should do this to all of our patients. So I'm going to throw this out there, and people know I make a big deal about this. We need to look at their sleep habits. Number one, it's hyperinflammatory, hypercortisol, stress. It causes a lot of disease. It worsens obesity. So how are they sleeping and their stress levels? And that's probably the first thing I would assess with the patients, because that's one thing we can mitigate. The other thing I would look at real quick too, because this is something we cause colleagues, and that is looking at what weight increasing medications they're on, either prescribed or over the counter. This is a problem. We're telling patients we want them to lose weight, but yet we're giving them medications that makes them gain it. And there's many of them. You can get it online, but a few of them we know. A lot of the, some of the antihypertensives, particularly beta blockers, can do it. ACE inhibitors don't. So you can see, charts will tell you which drugs can increase weight and what substitutes. But some of the beta blockers, we know that. Antidiabetics, like we know that. Insulin, sulfonylureas, pioglitazone, these can gain weight. Antidepressants. Not all of the SSRIs can be a problem. We see that for sure. One of the worst of the SSRIs I'm going to mention right now is paroxetine. So that one causes more versus, say, Prozac. So Prozac's a difference. And then you have the antipsychotics are the ones everybody knows. Risperidone and some of these things causes a lot of weight. And that's causing a real concern in the psychiatric field where we're looking at ways to help mitigate that. The other thing is there's a lot of others. Oh, by the way, the one thing I want to tell you to let you know about this, and that is the antihistamines at this time of year. Antihistamines can lead to some weight gain, mostly the early ones, the ones that you'll see mostly, colleagues, in NyQuil. Those are the early antihistamines, and they can put on a lot of weight if you're using them a lot. Even with Zyrtec and certainly Benadryl, a lot of those can lead to up to 5 pounds in a month if you're taking it. So be aware of that. So that's the big thing to be to look at. Also, ascertain readiness. You have to determine. I always ask, we find out why now. Once you can get them, first of all, is getting them interested in dealing with this. They may not be interested, and you can approach it. The big thing is there's a study that showed 80% of patients who struggle with significant adiposity want their providers to bring it up in a way that does not show judgmental behaviors, but bringing it up, that there's things we can do now. So 80%, and a lot of us don't want to touch it. We think it's going to make them feel bad, but I think they'll feel bad when they get sicker and deader earlier. So we want to bring that up. So ascertain readiness, and I'm always interested, why now? What were their goals? Remember, there are about 236 complications associated with adiposity and obesity. 236, including cardiovascular diseases, dementia. You'll see type 2 diabetes. You're going to be seeing cancers, 14 different cancers associated with obesity. So there's a lot of complications related to this disease. So we want to look at ways to mitigate that. So we want to set a right goal, and to mitigate, to bring blood pressure down and even improve blood sugar, just 5% of body weight. That's a goal. And that's doable. And then we can look at 10% is even more. You can actually start regressing NASH with 10%. So the higher weight loss you get, percentage-wise, the better, the decreased biomarkers of metabolic syndrome and the harbingers of things not too well to come. So you want to set it right. And I'll tell the patient, I will look at 7%, say, and for some patients, that might just be 16 pounds. That sounds doable. They go, okay, I can maybe do that. And you want them to know we're not looking at 70 pounds here. Some of them may, but we're looking at, there's enough to start them on the road to success as far as a healthier, state. There is, when you're looking at what to eat, I like to look at certain behaviors like binge eating or, carb craving. And this is very important to know. Binge eating, those who they start eating something, they can't let it go. They'll eat the whole. I had one patient say he loved Fig Newtons. He'd had one Fig Newton. He goes, and he'd eat the whole sleeve. He said he couldn't stop. Or Cheetos is a big one, or whatever. A lot of nocturnal binging too is a problem. So that's difficult to treat. And that's an OCD behavior, and that is something. They have to get psychotherapy for that, perhaps and some drugs. But carb craving is about 32% of patients, and they'll crave carbs. And I like to know what they're eating, and lets me know what they're dealing with, because there is an area in the brain, 32% of these patients who struggle with this disease there's an addictive, this is an area in the brain of the dopamine 1 receptors that we see with addiction to smoking, drugs, sex, ETOH, you name it, gambling. And it's in the same area, so they're addicted to carbohydrates. You can see by what they're eating. And I find it fascinating that I've never seen anybody addicted to kale. Can't explain that, it's carbs. So, when I like to know when they eat. Are they eat near the end of the day? So when they eating close to nighttime, you always going to pick up 25% more retaining those calories and holding on to them. You can increase weight the later you eat at night. I'm not going to get into the physiology of that. It's a biorhythm, circadian pattern of eating. So I like to know when are they eating something before you go to bed, and what are they eating, and how they feel when they eat, what's driving them. It's mood food, because we eat either because it makes us feel good. We eat because just to eat to fill the stores the brain's telling us we need it so we can move our muscles and think and breathe. So I like to find that out. You see, I'm not mentioning a lot right off the bat with diet, because if somebody asks me, well, Chris, is it keto better? Is it Mediterranean? Is it paleo? And all these different diets, I would say, okay. I'll say, sure, why not? Because there is no one diet that works for everybody. There is a lot of genetics involved. I mean, there's polymorphisms for those who do better with low carb, high fat diets. There's others, it's just the reverse. There's a palate issues. I think the big thing now in obesity medicine is looking at timing. Timing is a big deal. So when you eat it, there's all sorts of intermittent fasting can help some, not all. You're seeing some of the research, they go, this works, this doesn't work. There's nothing out there consistent. And again, because it's nutrigenomics, it's our genetics and timing of when we eat. So the big thing is reducing caloric intake may be the biggest thing, not eating right before you get to bed, and certainly not having refined sugars and or high fat content right before bedtime, because it tends to throw us into longer insulin resistance. But that's another whole lecture. When it comes to exercise, please understand that it's what we eat makes a bigger difference than exercise or physical activity. It's important to know what they're doing. They need to be moving. It's good for health, cardiometabolic health and cardiopulmonary health and brain, and you name it. We know movement, just movement is important, but you get tenfold the benefit by what you eat or don't eat. By the way, we push protein. Why? Because protein takes triple the amount of energy to metabolize that food than, say, carbs. Carbs is the next one, and fat takes less energy to metabolize. Remember, we want to utilize some of the energy, and you get more from that, believe it or not, than you do from running in the long run. So we do like exercise. If you're going to do that, we like to do some weights as well, because when you lose weight, about 24% of that weight will be lost from muscle. So we want to maintain the weight. And if you want to get good cardiac benefits, some of the research is indicating if you can walk 2 miles in under 45 minutes, best in the early part of the day, that seems to show some benefit. Or when you finish eating, biggest meal of the day, just get up and just walk for 10 minutes. Just walk for 10 minutes, and that's helpful as well. So there's a lot in there. There's no one way that works and benefits. And there's a lot of good data. By the way, if you want to get some information on that, I would recommend looking at the American Diabetes Association. There's the Obesity Medical Association and the American Association of Clinical Endocrinologists, and even the American College of Cardiology. They've all come out now with guidelines on this. So it's not just, I'm just showing you these are different things to look at. But I would look at that to look at different kind of diets to tell. There's no one diet, no matter what anybody tells you. Just telling you.
These are some great points to keep in mind for clinicians as well as patients on their weight loss journey.
Well, I hope so. They come in with so much confusion, misunderstanding, and a lot of the way they eat. For instance, if I may have time, a real quick point. A patient came in once to my clinic, and she worked on Capitol Hill, and she's 50s, metabolic syndrome looking, diabetes and the like, and came in. And she had adiposity, some adiposity. She had a BMI of about 31, 32. And I introduced myself, and the first thing out of her mouth was, "Don't mess with my bagels." Don't mess with my bagels. Like, don't mess with my food. And I've seen her for diabetes and a little bit of weight, and I don't do that right off the bat. If they have diabetes, I desugar them, I dejuice them. But I didn't. I said, she sat down immediately and she said, "Forgive me." She goes, "Please understand that food is my friend. Food is there when no one else is." So for her, food was important for her lonely state, her depression, or whatever. 6 weeks later, she came in, she lost 6 pounds. And I asked her what it was. Wow. And I said, "What happened?" She goes, "I cut back on my bagels." You know, she did it. She decided. By talking about, she understood what was driving her to eat. And it's because her husband had divorced her 2 years before and ran off with the secretary. It was banal. But anyway, that changed everything for her when she realized it. Now, that was hers. Other people's, the addictions, there's all different reasons for what drives people to eat. So again, what we do diet-wise and how we intervene, they're going to be their choice, but we just have to be there for them and guide them.
Weight loss drugs like GLP-1s, such as Ozempic, are being discussed everywhere, especially on social media with celebrities and influencers. What do you think is important for clinicians to understand about the new classes of weight loss medication?
Boy, have things changed. Am I right? Oh, my goodness. Do you know that in 2020, there was a study that came out that identified over 50% of the American adults that are eligible for taking anti-obesity medicines. However, only 2% were having them prescribed. I'm not saying those who are having denied. I'm saying prescribed, period. They weren't being utilized at all. And now it's exploded, particularly with the GLP-1s that you mentioned, Ozempic. Ozempic, of course, has been out there for a lot of years and has been out there for diabetes use. It's not for obesity, but they saw the side effects of this was weight loss. And I'll talk about that in just a minute because it's more than that. And if you're going to ask any of us in obesity medicine, what would you want patients on? GLP-1s and these incretins. These are gut hormones. By the way, just to reinforce my nerd pathophysiology geekness, I've been following GLP-1s since the early 2000s. I was following the first ones coming into clinical practice back in the phase 2 trials. And I saw then the benefits, the cardiovascular benefits that were there. It was going to be looked at for diabetes, but I could see all the things it can do with the metabolic disruptions that occur with metabolic syndrome, type 2 diabetes, and weight. And I was so excited that, in fact, I looked at all the patients I had who had cardiovascular disease to put them on the GLP-1 as soon as it got approved by the FDA, and I did. So I saw the benefits of these drugs, and I love them. But please understand, we have 7 anti-obesity drugs now. Some have been around for quite a while, and all of these medications do provide weight loss, and they're considered safe, which is really great because some of the weight loss medicines that were in the early 60s that started like fenfluramine and fenfluramine caused valve problems, and you had Meridia that came out in the 80s, 90s, and that caused hypertension. So the early obesity medicines, there was a stigma to have been unsafe, but the ones we have now are quite safe, and you can lose at least 5% body weight. And didn't I tell you that's what you want at least for? So if you can't get into the expensive drugs, we do have others that are out there if there's appropriate fit, looking at contraindications and side effects. And you can get all these drugs mentioned on any of these websites that have obesity guidelines. Remember, we have phentermine. It's been around for a long time, safe, the cheapest out there, and you can use this while you're waiting to get prior auth for some of the drugs you need. We know we've got Contrave, which is bupropion, and Naxalone, and that's been out there for a while. You've got Kissimmee, which I love, topiramate, and phentermine, which is long-acting low dose, and we've got Orlistat. Nobody tolerates that. I mean, just passing gas and putting out a lot of greasy stool is not just exciting. So that's never been well used. But then we have the GLP-1s that you mentioned in this question. And that came out years ago, at least 7 years ago, with liraglutide, long-acting. That's sort of what the Victoza, but long-acting, is Saxenda. That's been out for a long time. I've been using that for a long time, and it's successful. And then you've got Wegovy, which is the higher dose Ozempic. It's semaglutide, but we call it Wegovy in higher dose, we have just now got passed by the FDA is Z-bound, which is tirzepatide. Colleagues, it's the exact same drug as Mounjaro. It's the same drug, same dose. These other doses, GLP-1s are higher dose, but these are the same dose. One is that Z-bound, one is tirzepatide. Have no idea why they're doing it. But colleagues, these drugs are amazing if you can get them. Expensive. And right now, because everybody's been talking about them, the influencers have been out there. You have all these celebrities talking about, even Elon Musk was on it, and suddenly it's been a run. Tirzepatide or Z-bound just got approved. They're having, you can't get it. They're one dose. There's a dose you cannot get because there's been a run on it. So the same thing with Wegovy, Saxenda, and Z-bound. You cannot get, and this is really, a lot of people were using Ozempic early on when they couldn't get Wegovy because of the run, or they were having some problems getting what they needed to make some of the syringes. And so there was a run on Ozempic. So what happened? People with type 2 diabetes couldn't get Ozempic because people were using Ozempic off-label for weight loss. And so that's been a real concern. Why do we like these drugs? I got to tell you, it's amazing. Again, it's what it does with the other morbidities. These patients with obesity or adiposity have increased cardiovascular risk. This is what these drugs help. Not just type 2 diabetes, glycemic issues. You can give these drugs with diabetes, but you give this for obesity and mitigate the diabetes. It also works for cardiometabolic disease. Cardiology wants these drugs being able to be approved, that they can give it without diabetes, just adiposity and not obesity. They just want to use it to help with cardiovascular disease. Why? It's pleiotropic in the coronary arteries. Decreases heart attacks. GLP-1 is produced in the brain, and it's pleiotropic in the brain. It reduces some neurodegenerative diseases. You didn't hear that, did you? Oh, yes, indeed. These GLP-1s can do that. And I don't know why they sat on that data. It's been known. It also is reducing fatty liver disease, non-alcoholic or MASLD, the new acronym, but it decreases fatty liver disease. It decreases inflammation. It can decrease NASH dramatically. It cannot reverse fibrosis, but by golly, this has been amazing. And remember, non-alcoholic fatty liver disease is one of the biomarkers of cardiometabolic disease. This is all about cardiometabolic disease. It all comes out for metabolic syndrome. And this is what makes these so exciting. There's new research just came out looking at osteoarthritis, and colleagues just last week looking at these GLP-1s, and this is coming out of the Wegovy groups, semaglutide groups. A lot of this data is looking at improving colon cancer risk. So there's so much that's being studied right now. This is the drug to get if you can get it. Again, do you understand? This is a big take home of all of it. It's all about mitigating metabolic risks for these patients to help them to be healthier, to feel better, to live longer. Because colleagues, if you have family members or you yourself are between the ages of 20 and 39 and you have a BMI of 30 and above, you have just possibly lowered your life expectancy by 6 to 8 years. So this is something we have to pay attention to. Oh, and one last thing, because I know you're asking. People who are on GLP-1s, we found this with the semaglutides and liraglutides, that people aren't interested in drinking wine or alcohol. It seems to mitigate some addictive behaviors. So you got psych looking at that as well. So that's why I'm excited, and that's why I get all geeky out on the GLP-1s and incretins. By the way, tirzepatide is GLP-1 plus GIP, another incretin together. And these drugs, you'll lose 9 to 20% body weight, particularly with the Z-bound, up to 20%, about 15% or so. But remember, about 15% of patients, everybody's not going to lose that much weight. It's genetics. Some people lose a little. I know one patient who gained 3 pounds on a GLP-1, but most people lose weight, at least 5, 9, but it can be higher, 10, 15. Some have lost much more than that. So good stuff.
Thanks for sharing your expert insights on these quote-unquote trendy medications. What are the biggest barriers to attaining successful weight loss?
Well, I think the biggest problem that I've seen, just because I've been in this field for so long, I remember 8 years before I was blabbing on the concerns of this, before it got approved, the number one thing has been bias. And obesity is number 4 on the bias list, it's said. The biggest being race, then gender, then age, and then obesity. And I know it's nobody listening here, and to me, share this kind of idea, but I will tell you, when I started talking about obesity, I remember a colleague of mine, endocrinology, brilliant. And this was after 2012, where it was identified as a disease by the AMA. And I mentioned that. And he said, oh, I don't think it's wrong. It's not a disease. By calling it a disease, then you're going to give them excuse not to do anything about it. I go, is that what you tell diabetes patients? Are you kidding me? I'm telling you, there was a lot of bias back then. Now, more and more people, I would hear, just put down the fork. Just tell them to put the fork down. Just zip their lip. Don't eat. Are you kidding me? No. Number 2 is cost. You cannot deny it. Cost. And depends, again, it's not your insurers. It's the employers. And the employers are the ones to determine what they're going to cover. And so it's important that we keep ordering it, even if they're not going to be covered by the insurers. You know, it's HR. I've talked to a lot of HR to put this on their plans. And there's something out there. There's usually a PharmD or there's consultants to determine different employers. They're getting some insurance, and then they're the ones that determine what drugs they can approve. So cost is the big thing. And you'll see, and that's why you see a lot of celebrities using this drug, because they can pay $1,200 out of pocket a month for this drug. A lot of people can't. And don't worry about Medicaid. Medicaid is helpful. You can get it, but not all states. I think maybe 14 states Medicaid will cover. Medicare, forget. And the budget crunchers, Capitol Hill, I've been up there so many times talking to them. But the idea of allowing Medicare to pay for anti-obesity meds like GLP-1s, they said will ruin them, because there's so many people. This is the biggest, over 75% of adults all have adiposity. And we know patients, these drugs have been used on patients 70, 75. They can do that if they need it, but they said it's going to cost too much. We're running out of drugs, as I mentioned, with Zebound and Wegovy. There's inappropriate goals we mentioned. It's for metabolic health. You want to lose 5 to 10% body weight. The side effects can be intolerable. And for GLP-1, patients need to know that their patients need to know that, and how to take it and how to take it correctly, and be very aware of what the side effects could be in the patients. And the patients know this as well, but they're so wanting to lose weight so quick, they're going to take it inappropriate. A lot of patients will stop their anti-obesity medicines after they've lost weight. If they stop their medications, the weight's going to go back up. The body tries to defend its fat mass, and it will increase hunger hormone, drop satiety hormones, and drop resting metabolic rate. So patients' weight will go up if it hits a certain amount. And so the body's proclivity is to do it, whether you have bariatric surgery, whatever. So please, they shouldn't be going off those unless they're having a bad reaction or if they're pregnant. No woman should be on these drugs because they haven't been approved for that. If they're pregnant, in all of the anti-obesity medicine, they should not be on if they're pregnant. And then I think the other thing is looking out, it's a lack of hope and belief that they can lose weight. And it's a perspective that they think they're not going to be able to lose weight and keep it off because they've had so many failures. It's going to be a self-fulfilling prophecy. And so that's the biggest barriers.
Finally, are there any last points you would like to make?
Yes, I think the research is very clear that success comes in 2 ways. If you're going to use those weight loss drugs and or bariatric surgery, they can go into that. It all works better, 1, if they have a relationship with their provider. A non-judgmental. Research is very clear on this. They can do much better if they trust. And it's the touch points. We keep contact. I have a weight loss clinic now. I've just moved down to North Carolina. It's still up in Maryland with some of them, working with them. But you can just contacting them and keeping them going. That's important. The other one is that if you're going to use drugs, lifestyles essentially have to come together. They need to be doing lifestyle with drugs. You get double the efficacy. Start sooner, for heaven's sakes. Don't wait till the BMI is over 32, 34. We need to start sooner. If you have a patient who's got a BMI of 27 and 1 complication, colleagues, there's a lot of complications, sleep apnea, you name it. Then you're going to go ahead and start then in the pre-obesity state. Remember I said it's not numbers on a scale. It's adiposity. If you have central adiposity in a perimenopausal woman, she's not obese, but she starts putting that weight around the middle. You intervene. BMI of 27, start. If they're Asian, BMI of 23. It's the adiposity. And people who carry weight around the middle and up. Oh, here's another one. If they got a skinny rear end and skinny legs, but they're carrying the weight in the middle and up, worse cardiovascular risk and insulin resistance. So we go skinny butt, big gut. Those people that were, the research is very clear, or somebody who's thin or lean but has a lot of adiposity in the middle. Those are the highest cardiometabolic risks. Then ones who have carry weight all around. But you want to start early. Don't wait, because they will not be able to keep the weight off if you do, and there's a progressive disease. And you don't need to lose a lot of weight to get the benefits I mentioned. It's a lifelong therapy, as I mentioned. And by the way, you can use anti-obesity medicines before bariatric surgery, and you can use them after. So that is something to pay attention. And also all these things out there, Noom, people ask, what are these apps? All that will work. It's all beneficial. Just use whatever's out there to get your patients engaged, that they're paying attention. But most of all, give them hope. Give them hope.
Thanks so much for your time today, Christine. We really appreciate it.
It's been a pleasure. And thanks for listening to all of you out there. I know you're doing a great job with all your patients. I know you are.
You can catch Christine for her session on cardiometabolic disease at the NCNP 2024 Spring Virtual Event held April 24th through the 26th, 2024. Thanks again for listening. For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.